Our next speaker is Fred Nicholls. He's going to also talk about PJK, lumbar flatback. Do both need to be corrected?
All right. So I'll try and get us back a little bit of time here. So Nicholls asked me to speak today about PJK and flatback and whether both need to be corrected. And that was my answer. And I struggled a little bit as to what else he might want me to put into this talk. And what I came up with was that, honestly, if it was easy, anybody would do it. So no relevant disclosures. I'm going to start with a little case here. So this 65-year-old woman, not a lot of documentation on her original presentation. She showed up before our provincial EMR was in place. And somebody did this T11 to S1 on her and got this 3-month post-op x-ray and continued to follow her for 4 years post-op, 8 years post-op, and eventually decided to refer her to me 11 years post-op, which is the first time that we got long-standing films. And at this point, she's really not walking around very well. She's using a wheelchair for any significant mobilization. She's deconditioned, has some comorbidities, and her numbers are terrible, right? Like her lumbar spine, she's 16 degrees kyphotic. This is a flat back, right? And you can see that she is fused, all posterior, which is a little bit odd when you look and you see that she's got that vacuum in her 5-1 disc despite that. And if you go back through those images, and I won't belabor it, but you can see that through that 4-5 spondy that she originally had with that tall disc, she slowly kyphosed through it despite this like apparent robust posterior fusion mass and her instrumentation. And T-score lowest was minus 1.8 at the hip, but Hounsfield's weren't terrible when you look at the segmental levels. I'm not going to ask anybody about that, but this was my surgical plan. I was going to take out the instrumentation, clean everything out, and then revise her instrumentation. I thought I would need to go up into the upper thoracic spine to really control the lever arm. And I planned to do 2 PSOs, L2 and L4, to try and get that corrected. And as I was shown at the time of my fellowship, I was, thank you, going to put some laterals in after to make sure that it fused. And it didn't go that great, to be honest. So we had a lot of blood loss. We got about 5 liters. There was a dural tear in the section of the revision decompression, and the anesthetist told us, that's it. We're not doing a second PSO. She went to the ICU for 3 days post-op, and when she came out, a little bit because of her time in the ICU, a little bit because of the pain she was in, she said, I'm not going back. We're not doing a second PSO. And so how did her numbers look at the end of that? Well, not awesome. So, we got a reasonable number of degrees of lordotic correction, but you can see that she's still forward. Her L1PA is still elevated. Her T4L1 hip axis would indicate that she's still severely undercorrected. Is there a reason that keeps happening? There we go. Oh. And so at 2 years post-op, she was improved from pre-op, but she's not satisfied. I mean, she still can't stand up the way she wants. At 5 years post-op, she starts complaining of some junctional kyphosis, but she refuses to have a revision. At 6 years post-op, she shows up in the emerge with myelopathy, and this is killing me. Okay. But she refuses an extension up into her cervical spine. She refuses a comprehensive procedure. She won't let me do the second PSO. She's like, bare minimum. So I extended her up to T1 and left it at that. And now 7 years post-op, she looks even worse, and her back pain is getting worse as well. And when you zoom in, you can see now at this point, 7 years out, she's broken a rod. 10 years post-op, yeah, it's been that long since I was your fellow. 10 years post-op, she comes back and she's back in the wheelchair again most of the time. And at this point, she's like, no, it's time. Do everything. I want to be realigned. But she had an adrenalectomy for aldosteronoma. She's got severe osteoporosis. Her T-scores are about -3.5. And she's developed severe pulmonary hypertension on top of it. And these are her films. And the anesthetist says, it's not happening. She can't go back. So with this demoralizing case in mind, we're going to talk about PJK in the setting of flatback. And to do that, we need to kind of define what flatback is. So we can look at this x-ray and we can say, that's clearly flat, but how we define flat has changed over time. It can be from a lack of segmental lordosis according to Bridwell's means. It can be from the PILL mismatch from Schwab's criteria. Within the GAP score, we have the relative lumbar lordosis and the lumbar distribution index, or it can be that the predicted L1 PA is greater than half of the PI minus 19. It's not that any single one of these definitions is absolutely wrong. I think that it's more that as we've moved through them, we've developed more of a nuanced approach to how we look at what flat is. And the relevance of flatback is how it affects your overall global alignment. So each one of those definitions for flatback comes with a different measure for global balance, but the principle all boils back to Dubusset's cone of economy and whether or not you can keep your head over your pelvis in that setting. So whether or not you're keeping your head over your pelvis and whether or not you're left with a biomechanically optimized environment is only one factor as far as the etiology for PJK is concerned. There's patient factors, mechanical factors, and also your surgical technique can affect it. I won't belabor that because Michael just gave you a whole talk on it. But and so really why we're trying to get that balance is to get that optimal biomechanical environment and prevent people from falling off the top. And what do we know about the association between restoration of alignment and PJK? There's been quite a few papers that have been published on that. And when we go back to the initial papers on PJK, 2010, 2011, they talk a lot about spinal harmony and whether or not the thoracic kyphosis and the lumbar lordosis are within the same realm, whether equal, whether one is greater than the other, and when we look at Yagi's paper from 2010, how the pelvic incidence affects that as well. So when we look at the then when we shifted from that definition of spinal harmony over to looking at Schwab's criteria, we start looking at whether the SVA is elevated, and we take that as a sign of global imbalance. And a couple of papers, especially from UCSF around 2013, 2017, we can see that with elevated SVA, we have an increased risk of PJK. Kim's paper in 2019 showing increase in PJK with an SVA greater than 8 millimeters above. So on the flip side, the European Spine Study Group is looking at the GAP score, and they suggested there's an increase in mechanical complications with a residual high GAP, but follow-up papers seem to fail to show that same correlation. But when we break GAP down and we start looking at the lordosis distribution, that's where we do start to see if we get that wrong, then we do have an increased rate of junctional kyphosis and failure. There's a great paper from 2024 from Pizzones that talks about different ways of evaluating the sagittal plane and which one is the best. And while the Russelli morphotype didn't really have a good predictive ability, the GAP score did, in their paper, show good correlation with increased mechanical complication. Now, they also looked at the T4L1 hip axis, and I think we've seen these exact pictures about a dozen times today, but increased rate of mechanical complication when the T4L1 hip axis is not restored. And when we think about Flatback and PJK, we're kind of talking about the first column there, where T4 is ventral to L1 and the L1 PA is undercorrected. So that is a Flatback with a junctional failure over top of it. And that's exactly what Pizzonis showed in his review of assessment of global balance and which method is the best, that the T4L1 hip axis was predictive of junctional failure. This year at the SRS, there were 2 papers that also were presented that found the same thing from Karaman. 72% of the patients in their group that had mechanical complications failed to meet their ideal L1 PA. And he found that meeting the ideal L1 PA was protective against junctional failure. Lenke's group in Colombia showed, when he broke down the T4L1 PA difference between what they considered to be reasonable, what they considered to be like moderately off and severely off, that the people that were severely off had a far greater rate of junctional kyphosis, and that each degree of increase of the T4 pelvic angle over the L1 pelvic angle carried an additional 1.26 odds of failure. So in the end, taking all that evidence into mind, it's reasonably convincing that if you're going to leave somebody flat, if you're not going to correct them completely, you are putting them at increased risk of mechanical failure. So leaving the flat back there means there's going to be global imbalance, regardless of how you define it. And that increases your risk of having further junctional failure. So one more case here. This is a 73-year-old. He came to me previously highly active, pretty healthy guy. He had been just walking about 15 kilometers a day in Europe. And he says, look, like I had an L2 to 5 done. I couldn't stand up quite straight afterwards, but I was able to get back to what I wanted to do because my legs weren't bothering me anymore. And here are his films. And he is very positive, and he's very flat through his 2 to 5, and he's got this junctional kyphosis. And I'm sure in this room, you guys have seen this before, but to me, this was the first time I'd ever seen somebody with a negative sacral slope. Like, to me, sacral slope usually stopped at 0 and didn't keep going back. But this guy, he's managed to rotate his pelvis so far that he's got a negative sacral slope. And part of the reason we can see once we get our axial imaging that he's got this kind of canal filling disc herniation at the bottom at L5S1 that he's trying to maintain some kyphosis to offload his nerves and at the same time strain on his upper thoracic spine to get standing up straight. Now, looks like he's got a fracture through the top of his L5 there, and his cage has spun out, but it is fused. His bone was good. He has T-scores of minus 0.7, supranormal Hounsfield units. He's a non-smoker, doesn't take opioids. And so I decided to do a stepwise release on him. So pre-incision long films, and you can see his thoracic kyphosis corrects really well. It's mobile. You can see the 5-1 disc opens up really well. The one thing I'll point out is back here, he has an extremely aberrant left common iliac vein. And so I don't have an approach surgeon. And when I see something like that, I say to myself, that is a vascular injury waiting to happen. And so I did not go in that way. And so I elected to do instrumentation only up to T10. I told him we might have to go to T4, but when we saw how well he corrected prone, I thought T10 would be fine. And then do stepwise releases, posterior column osteotomy at the bottom, posterior column osteotomies at the top, take another long film, and then measure out what PSO we would need, which is exactly what we did. Less blood loss than the case before, tether at the top for junctional failure prevention, and he's standing up fine and doing very well. right? You can see his parameters are all corrected to whatever measure you want to take. And so I think it's important to think about the changes that what we've changed between the first case and the second case. What I've changed, I mean, a lot in 10 years of practice between those two. It's part of it is the way that we optimize our patients. Part of it is how we select them. Part of it is how we plan for it. But if I'm being critical, when I think back to when the first patient got out of the ICU and she didn't want to go back to the OR, I was 18 months into practice. I was relieved. I didn't really want to revisit that. I had a hard time on the first day and I kind of let it lie. And on one hand, I don't think that we should talk our patients into something that they don't want. My experience, every time we try and convince somebody to have an operation that they're not really interested in, those ones go worse than anything else that we can do. But on the flip side, I probably could have framed it differently. I could have presented the risks of leaving her the way she is differently, and maybe she would have been more mobile over the last decade. So, at the end of the day, we know that persistent undercorrection is only one of the risk factors for ongoing PJK, but it's an important one, and it's one that we ultimately have control over. And so you can go back to my second slide. I still think the answer is just simply yes. And the only reason I think we're debating it is because some patients are not well. And we factor that in and we worry about putting them through it. But ultimately, I think you need to do the right operation and optimize people appropriately if you can. So, thanks.
Munish wants that. I know this. Okay, go ahead. Only Munish.
I think that, the one thing you shouldn't forget is when you're starting out and you're doing these big cases, you should not frame it like, let me get everything done today. It's actually the opposite. Maybe plan it differently so you're going to have a planned approach of this is what you're going to do and that's it. And then not get into the 5 liters of that situation. And then you plan to come back. Then you have this less stressful, less painful for you, the anesthesiologist, everybody else. That's something you should not